Treatment for prostate cancer must take into account a number of factors. First of all, an assessment of the patient's overall health status and other medical issues is very important. This also involves an assessment of really the patient's life expectancy. Now, determining an individual person's life expectancy is a very difficult thing, but it does play an important role in discussing options which may be most appropriate. In addition to assessing the patient's overall health status, the characteristics of the tumor, that is the grade, the stage, and the PSA, that determines the risk category of the patient's cancer problem and also helps select appropriate treatment. Finally, and very importantly, in most situations of prostate cancer, there are more than one option, and a patient's preference, considering their own ideas and considerations of benefits and trade-offs, is extremely important. For patients with early stage prostate cancer, there are typically a number of options available for them. I think most importantly, it should be noted that not all men with low stage prostate cancer require treatment. Nowadays, we often find prostate cancers that are very low volume, indicating that there's not much cancer within the prostate. These patients who have a small amount of prostate cancer that's not very aggressive, oftentimes will have a cancer problem that is not an immediate threat to their life and may only pose a threat to their life given 10, 15, or even 20 years. So older patients in their 70s and above, many times aggressive treatment is not necessary. And currently, a strategy of what we call active surveillance is recommended for many of these very low-risk patients. Active surveillance is not just forgetting about the cancer. It is monitoring the cancer very closely. Patients are typically seen 2 or 3 times a year, and oftentimes will need to undergo repeat biopsies to assess their cancer situation. But the idea is not to aggressively treat the cancer, thereby avoiding the potential risk and complications, but monitoring it such that if the cancer shows signs of worsening down the road, treatment could then be instituted. The goal and hope is that at that point in time, their chance of being cured is still quite good. And so active surveillance is a strategy that most men with early stage, especially low-risk prostate cancer, should consider. The 2 primary treatments for localized prostate cancer, which is cancer that has a high probability of still being confined to the prostate, is either surgical removal or radiation therapy. Surgical removal in the United States is most commonly done using a robotic-assisted laparoscopic technique. This is a minimally invasive surgical procedure that results in typically a 1-night hospital stay and very low perioperative morbidity. Patients get back to work quite soon, but it still has the traditional risk of prostate cancer surgery, which are urinary incontinence as well as sexual dysfunction. Radiation therapy can be done in a number of ways. The most common technique for radiation therapy is using an external beam source to deliver the radiation to the prostate as the target. And there have been a lot of improvements in targeting therapy over the last decade, which has resulted in improved cure rates with radiation therapy and less morbidity or toxicity from the treatments itself. In addition to the external beam option, some men are also candidates to have what we call brachytherapy or a radioactive seed implant done. This is where the radioactive source is actually put into the prostate by placing a number of radioactive seeds throughout the prostate to deliver the radiation from within the gland. It's given off over a period of 3 months following an outpatient surgical procedure to implant the seeds. Not all men are candidates for brachytherapy, however, and careful selection is very important to good outcomes. Men must have a prostate size that is not so large that the seeds can't be placed properly, and they shouldn't have a lot of voiding symptoms or problems with urination prior to having a seed implant. For patients who have prostate cancer that on testing and examination are felt to have a high probability of being outside the prostate but no other spread, the most common treatment is a combination of therapies, and this involves most commonly the use of radiation therapy and adding to the radiation therapy hormone treatment. A number of studies have clearly shown improved survival in patients with these harder to treat prostate cancers when hormone therapy is added to radiation treatment. The length of hormone therapy is determined by a number of factors and may extend from either 6 months, sometimes up to 3 years, depending on the risk of a patient's recurrence. Occasionally, surgery is also considered for some patients who have potentially prostate cancer that is extended outside the prostate, but is much less commonly used than the combination of hormones and radiation. For patients with more extensive cancers, as well as spread to lymph nodes or even more advanced disease, the mainstay of treatment is hormone therapy. When we say hormone therapy, what that typically involves is administering a shot that is given either every 3 or commonly 6 months. What this does is stops the man's production of male hormone. The primary male hormone, testosterone, which is produced in the testicles, circulates throughout the body, and wherever prostate cancer may reside, I tell patients it functions like fertilizer. It feeds the cancer, makes it healthy, makes it strong. By blocking the production of male hormone, a lot of prostate cancer will die, a lot of it will stop growing. But it's important to note that hormone therapy is not a cure because it doesn't completely eliminate the cancer from one's body. Ultimately, prostate cancer can evolve over time, and in patients who have been on hormone therapy, ultimately the cancer can learn new ways to grow despite not having the male hormone around. That is a situation that we refer to as hormone-resistant or castrate-resistant prostate cancer. Hormone-resistant prostate cancer has traditionally been a very difficult situation to treat. Very excitingly, due to a lot of research in this area, over the last decade there have been a number of exciting breakthroughs, and we have improved our ability to help patients in this situation. Once the cancer recurs or progresses, despite being on hormone therapy, there are a number of potential options that a given patient may be best suited for. Occasionally, chemotherapy is used in this situation. Recently, a number of what we call secondary hormonal manipulations have been developed that have been shown to improve survival and quality of life in this patient population that is very difficult to treat. Finally, there are some immunotherapies that have been developed for use in castrate-resistant prostate cancer. These have also been shown to improve survival as well.